I'm Harti Selvan, going to talk about the management of cyclodialysis. Cyclodialysis is the disinsertion of the longitudinal fibers of the ciliary body from the scleral spur, which results in hypotony and hypotony related complications. The surgical management of cyclodialysis can be by two types. One is cyclopexy, where it is suture-aided fixation, and cyclotamponade, where we use extraneous agents, especially the IOL haptics or ring segments or segment tamponade, so that it provides apposition to the ciliary body from an internal side. Direct cyclopexy is considered the gold standard, by which a total scleral cut down is made, the cleft is identified, and sutures are passed through the ciliary body and through the sclera, and it is sutured under direct visualization. Since a scleral cut down is being done, there are high risk of complications such as hemorrhage, intraoperative hypotony, inadequate suture passages, cataract, RD, etc. On the contrary, Cioni endotamponade is a closed globe procedure by which we insert a single eyelet or a double eyelet Cioni ring into the sulcus and suture it onto a partial thickness scleral bed and tighten it so that it gives an inside-out apposition of the ciliary body. It acts by two mechanisms: directly by abutting at the site of suture and by giving a circumferential tamponade. I present a case series of 5 cases in which we operated purely by internal techniques and I'm going to talk about the success rates. The first two underwent only Cioni endotamponade. The third was a more extensive dialysis, and so we did a dual endotamponade technique. The third had triple dialysis and we did triple repair. But the fourth one had failed, where we did an internal cyclopexy again, which was a modified sewing machine technique, and the last was single pivot technique, which I'll be explaining in successive slides. This is the patient of dual endotamponade, where we can see a very large 300-degree cyclodialysis, for which we had placed the IOL in the sulcus with the haptic oriented towards the cleft and a Cioni tied onto the sclera in the area of the cleft, so it provided dual endotamponade and successive closure of the cleft. Next was a case of double dialysis. The patient had iridodialysis and cyclodialysis. We did a single pivot technique, whereby we put a Cioni ring in the sulcus, and the suture that was passed through the Cioni was also passed through the iris, and both of them were sutured at the same point, so that a single suture pivoted both the tissues at the same point. This was the intraoperative picture. And this is the third case, where we had triple dialysis, where there was iridodialysis, zonular dialysis, and cyclodialysis. Here we did triple repair of all of them in the same sitting. The first was correction of the zonular dialysis, where we placed a multipiece inside the bag and a CTR inside to manage the zonular dialysis. Then we did a Cioni aided fixation of the cyclodialysis. Then we did iridodialysis repair by stroke and dock technique. This was the intraoperative picture, and this was the postoperative picture. But this patient, even at 3 months postoperative period, showed hypotony, where we perceived it as failure, and we looked into the cause of failure. We saw that the Cioni, since there was zonular dialysis, there was inadequate sulcus and the Cioni ring had tilted. So it did not provide circumferential tamponade on the ciliary body, and it was confirmed on UBM. So we did a modified sewing machine technique, whereby we passed sutures from inside out like a sewing machine. We took multiple suture loops and then tied it outside, whereby the single suture passed multiple loops and corrected it by a single technique. This was the intraoperative picture, and the postoperative picture shows the closure of the cleft. So coming to the review of literature, our series, we had operated 5 eyes in which the primary success was 80%, 4 out of 5. But when the one single eye which was failed was reoperated, it succeeded, giving a success of 100%. So comparing it with what is there in literature, the external method, there are 2 landmark papers by Ioannidis et al. And Agarwal et al. Ioannidis et al. Said that after a single intervention, the closure rate was only 50%. And Agarwal et al. Had given a total cumulative of 94%, in which a few eyes had undergone multiple interventions also. There was a recent paper which compared the external methods of closure and internal methods, and they said they had 62.5% success in both. And there was one more paper which compared multiple methods. It was a multicentric study where they had used external methods, internal methods, cryopexy, and laser closure, and they said the total cumulative success was 93.8%. So we would like to propose that in the presence of cataract, phaco and endotamponade would be a better technique rather than an external cyclopexy. And in the presence of other associated traumatic injuries like iridodialysis, we can go ahead with a single point pivot technique. In zonular dialysis, we can initially try a endotamponer, but in cases of failure, we can do an internal cyclopexy like modified sewing machine technique. And in cases of RD, then we might consider other types of tamponer like gas or oil after vitrectomy. So comparing the advantages and disadvantages, external cyclopexy, it has higher risk of complications like hemorrhage, retinal detachment, etc. And since a full thickness scleral cut down is required in cases of extensive cyclodialysis like more than 3-4 clock hours, we cannot do an entire scleral cut down. On the contrary, internal cyclopexy is a closed globe technique, and it provides circumferential tamponer irrespective of the size of the cleft, and concurrent injuries can also be managed, and any anter-segment surgeon can proceed with. So the conclusion is that the traditional exocyclopexy, which was extend based, can now be underplayed because endocyclotamponade provides circumferential tamponade, and the primary success in our series is 80%, and the overall cumulative success is 100%. The Abinturner techniques are equally provide good success and are equally safe, and these can be considered as an alternative in cases of cataractous lenses, pseudophakic or aphakic eyes. Thank you.